We fight about band-aids in this country. The left says more subsidies. The right says more market. And yet, regardless of what they do in DC, your premium continues to skyrocket every single year. So here's the grown-up answer in plain English. America doesn't buy more healthcare than other rich countries. We buy roughly similar stuff, but we pay significantly higher prices for almost everything. And we run the money through a machine that burns cash on administrative nonsense. And that all gets passed on to you. Incredibly high prices and absurdly unnecessary complexity. That's what's causing this wound. Everything else is just a freaking band-aid on it. Let me show you the prices part first. All right. Think about an MRI. In other wealthy countries, a public agency or a national insurer says, here's what we'll pay for an MRI. One table, one number. Yeah, there you go. In the US, every hospital system negotiates a different price with every insurer, then changes it year to year, then wraps it in a contract the public can't even see. The same scan can cost triple across town. That's not because our machines are magical in one location or the other. It's because our prices are set in fragmented tug of war, where the biggest hospital systems often have the leverage to say to the insurer, take it or send your patients somewhere worse. When the seller has more power than the buyer, the price goes up. And yes, the price continues to go up. Prescription drugs tell the same story. New medicines get patents and exclusivity on purpose to reward risky research. We can argue whether or not rewarding that actually benefits us or harms us another time, but other countries respond by saying, fine, but we negotiate a fair national price. And if the drug can't be sold for that price, we'll wait or we'll just go without it as a country. The US mostly didn't do that for years. We split buyers into 100 different groups: employers, unions, insurers, pharmacy, benefit managers, Medicare Part D plans. There's a ton of different ones. And we told each one to negotiate alone. Fragmented buyers versus one manufacturer with a legal monopoly is not a fair fight, which is why the average American price for a brand name drug is 2 to 3 times higher than in peer countries, even after rebates. And yes, you've heard the industry's line. High US prices fund global innovation. There's definitely truth in that. The US is pharma's most profitable market by far. And expected profits do affect how many new drugs get pursued, but that's not the whole story. The basic science behind a lot of breakthroughs is actually funded by public research. Companies do still launch in lower price countries, even though the drugs sell for far less because those markets are so large. So the real question isn't innovation or affordability. It should be, how can we push prices down so Americans can get their meds without going bankrupt while still rewarding true medical breakthroughs? Other countries do that balancing act every single day. It's a shame we don't at least try to do the same. Now, the complexity part that I referenced earlier. The part you feel even when you don't step inside of a hospital. Our system is a labyrinth. One plan requires a prior authorization. Another plan needs a different code. A third plan denies the claim because the clinic checked the wrong box on page 22. Every one of those little frictions costs money, and it adds up substantially. Billing staff, denial teams, contract managers, auditing softwares. appeals departments. It's not one bad actor. It's the entire architecture. When you take the same MRI and route it through that paperwork obstacle course I just talked about, the total bill is higher before a single patient gets healthier. Other countries spend a lot less on that overhead because they simplify the rules at the top. One main set of benefits, one main price schedule, one set of forms. I'm not saying a single payer system is our only saving grace here, but we built the most unnecessarily complex machine to pay for healthcare and then act surprised when it costs a fortune in administrative costs just to keep it somewhat alive. People always ask me, isn't part of the price gap just that our doctors and nurses earn more? Yes, clinical pay is higher here. That's definitely a part of it. And that does push prices up. But even that has reasons under the hood that we don't see or don't pay attention to. We make the path to practice longer and more expensive here in the US. A typical physician goes, to college, med school. With six-figure debt, they go into residency, And that residency is bottlenecked by a federal cap on training slots from the 1990s. By the time you're finally in attending, you've delayed earnings for a decade and a half. The salary has to clear not just, the skill you've acquired, but debt, delay, years spent studying or working for 12 hours straight, and the overall risk you took in yourself just to get there. We pay for all of that. Nurses here carry debt burdens too, and then they end up spending a huge chunk of time on non-clinical tasks. Charting for billing codes, wrestling prior auths, and jumping between incompatible softwares instead of actually providing care to the patients in their hospitals. Add higher malpractice premiums and the fact that hospital systems price services to cover all those labor costs too, plus capital, plus the administrative army we just talked about, and you see why a visit gets billed higher here, even when the medicine or care that we're receiving isn't any different. Now, notice what I didn't say. I didn't say Americans see the doctor twice as often here. We don't. When looking at how often we visit a hospital and how many days we spend there, we're often lower than peers. I didn't say our insurance is wildly more generous. A lot of countries cover more upfront than we do and still spend less. And I didn't say the problem is simply greedy insurers. Plans do take admin and profit. But most of your premium pays hospitals, clinicians, and drug makers at higher allowed charges set by the power dynamics of our markets. There are actually rather robust regulations and incentives to make sure insurers aren't pocketing too much profit. That's something no one talks about. But if you don't fix the prices and you don't simplify the maze, moving who pays, whether it's government, employers, upper class, lower class, middle class, it just moves the pain around while we continue to pay significantly more. So when both sides sell you Band-Aids, here's what you can ask that keeps the conversation honest. How are you lowering the allowed price of common services where there's no clinical reason for us to pay double? How are you strengthening competition where one hospital system owns half the city? How are you aligning drug prices to real clinical value without killing all the innovation? How are you cutting administrative waste by standardizing rules so doctors and nurses spend more time on patients and less time stressing on insurance portals? If the answer is we're adding more subsidies, that's not a fix. That's just shifting the pain. If the answer is we'll unleash the market, but the market is 3 giant hospital chains and 1 PBM, that's not a market, right? That's a monopoly. Here's the unfair part you're feeling and the fair part that you should demand. The unfair part is that Americans have been the world's premium customers, paying higher prices for the same molecules and scans and stitches, because our system let it happen. The fair part is that we can cut those prices down to size and still reward what's worth rewarding. Great outcomes, real breakthroughs, and clinicians practicing at the top of American ability to provide healthcare instead of worried about admin. That's not left versus right. That's just refusing to get taken advantage of. If you want our premiums to stop skyrocketing in price, it won't be because Democrats created more subsidies or expanded government-based healthcare. It'll be because we finally told the truth. The same MRI should not cost 3 different prices on the same street. The same pill should not cost double here because we negotiated in 50 pieces instead of 1. And the money we do spend should go to care, not to a maze designed to bill for that care. Fix that, and the Band-Aids won't have to be so big. The Band-Aids won't be important. Now, this is all important right now because the government basically shut down over enhanced ACA subsidies and Medicaid cuts. So I want to answer a few of your questions you submitted to me on Facebook and Instagram regarding how all of this healthcare cost talk, relates to our current shutdown. Are Democrats really shutting down the government to give illegal immigrants free health care? Not directly. To summarize it very quickly, part of the big, beautiful bill that was passed earlier this year made less people qualify for Medicaid. Some of the people that will no longer qualify are migrants that have been granted asylum. Now, these migrants, or asylees, are technically lawfully present to be here in the U.S. But a lot of people argue whether or not Biden allowed far too many people to qualify for asylum that probably shouldn't have, which is why you hear them referred to by some as illegal immigrants. So basically, Republicans cut Medicaid for people like asylees and refugees because they don't want to incentivize people coming here for government benefits. These people are technically lawfully present, but some argue the only reason they qualify as lawfully present is because Biden's administration allowed everyone to qualify for asylum even when they should have been denied. And these people are therefore illegal immigrants that Democrats want to receive Medicaid. Which then becomes Democrats shut down the government so illegals could get taxpayer-funded health care. I hope that clears it up for you. At least a little bit. All right. Do you agree our health care is too expensive? Yes, I do. I mean, the average American spends twice as much on health care as our peers overseas do. But we never try to address the real issues that cause this enormous price difference. We're always focused on insurance companies, but insurance companies aren't the reason our premiums are so expensive. Our premiums are so expensive because the healthcare we receive is so expensive. What hospitals charge us is insane. What pharma companies charge us is insane. And like 8% of all healthcare we pay for is actually for administrative crap compared to the 1 to 3% they pay in other countries because our system is so complicated. So yeah, our healthcare is far too expensive, but it's for deeper, much more complex reasons than we're led to believe. Politicians like to make it sound simple because it makes them it makes them easily able to identify a villain and craft fundraising messaging around that. Are Democrats wrong to demand Obamacare subsidy extensions? Yes, because it doesn't address the real issue. Healthcare is too expensive for everyone in the country. I don't care whether you're upper, middle, or lower class. These Obamacare subsidies basically allow taxpayer money to cover a large percentage of your insurance premium. But that is still being paid by taxpayer money. I'd rather we address our med school students that go through financial hell getting their education, and we find a way that they don't get out of school with $100,000 in debt. which in turn makes our hospital bills more expensive. I'd rather find a solution to, Americans paying nearly 3 times what other countries do for the same drugs. And I'm thankful that that's at least kind of on the Democrats' radar. And I'd like to find a way to stop us from paying more than double what other countries do just for healthcare administration because our healthcare system is so broken. Fix these core issues instead of just throwing another Band-Aid on a growing issue. All right, guys. My camera's on 1%, so those are all the questions I'm going to address today. Thank you so much for watching. If you want to contribute to these videos and ask questions or, submit statements, follow me on Instagram, and I'll be able to see them there.